So now we are going to move to another defects of von Willebrand factor. So we have been, discussing inherited von Willebrand disease, and now we are moving for the last part of this, state of the art of von Willebrand disease about acquired von Willebrand syndrome. These are my disclosures. And this is my first slide where I'm trying to summarize, to outline my presentation. And I would like to draw your attention in the title because this is a question that I've been asked several times by many colleagues, hematologists and non-hematologists. Is the acquired von Willebrand syndrome a bleeding disorder or just a lab von Willebrand factor abnormality? I don't know about you, but according to my experience, I have experienced, as I can say, several cases where the bleeding symptoms were really relevant. So I will try to convince that it's better for us to understand when we are dealing with patients with acquired von Willebrand syndrome. And I will do by try to discuss the definition, the mechanism, the prevalence, and among several conditions where the acquired von Willebrand syndrome can be associated with, I would like to focus mainly on the most recent evidence about cardiovascular disorder and of some hematological disorder that that are the most the two categories where we can find von Willebrand factor defects in acquired conditions. Let's start with the definition. It's certainly a very rare bleeding disorder, and we don't have to work about too much about the diagnostic approach because is really similar in terms of laboratory finding to what we have heard by Dr. Eichenborn about the inherited von Willebrand disease. And of course, if you have a general screening, most of these patients can have a prolonged bleeding time they had in the past. We don't measure bleeding time anymore. But if you do the screening, some of these patients can have a prolonged PFA, for instance. But the most important thing, they show always a defect on von Willebrand factor activities, and we will show how this occurs. But the only difference is mainly related to the history, because these abnormality, if you can just ask questions when you have your patient in front of you, all these bleeding episodes occur later in life in subject without personally and family history of bleeding. So this is the main distinction between inherited and acquired. What about the data reported in the literature? You know that the first publication was produced in blood, was found in blood in 1968. And this was a small cohort of patients with defects of von Willebrand factor acquired associated with lupus erythematosus systemicus. So something that was related to immunologic abnormality. And in that case, in this group of patients, they found, autoantibodies interfere with von Willebrand factor. But then, if we check the literature until this was a recent review of the literature until last December, we found 622 scientific reports, 7 national expert recommendations, 1 prospective and 4 retrospective study, and, believe it or not, 2 hour treat in blood. But if you go to check evidence-based information, and if you go to the Cochrane database, no reports has been found. One of the major comparison between the most important comparison between acquired von Willebrand syndrome and other disorder acquired is acquired hemophilia. And everybody knows that acquired hemophilia is associated with very severe bleeding. And some of our colleague hematologists working in acquired hemophilia say, come on, don't think that the acquired von Willebrand syndrome is not really a major problem. The acquired hemophilia, it is real a serious problem. But why is the difference? Why we can find the difference? Just because as we pointed out with the inherited patients, there is difficulties on making diagnosis. And the difficulty is very, very high. We have very difficulties because we don't have a simple and unique mechanism producing the acquired von Willebrand syndrome. Acquired von Willebrand syndrome can be done, you have a normal synthesis, as you can find here. So the von Willebrand factor is produced normally. There is no major abnormality inside the endothelial cell, for instance. And so the von Willebrand factor can be released into the circulation as it does in normal subject. But something occurs into the circulation. Of course, mechanism A is exactly the same as we can find in acquired hemophilia. So we have autoantibodies, blocking the activity of von Willebrand factor. So we have immunocomplexes like these. And so, but we have also other mechanisms. And the other mechanism, the main other mechanisms are certainly the abnormal receptors in the circulating cellular. Most of these are related to hematological conditions. But also, we have also high stress abnormalities in the heart, where we can have a loss of large molecular multimers because there is high activated platelets and high interaction between platelets and A1 domain of von Willebrand factor. So we have high propeptide, but very high propeptide and very low level of von Willebrand factor antigen. Last but not least, we have a condition like hypothyroidism, where the biosynthesis from endothelial cells can be reduced. So the message to take home is that, okay, we have autoantibodies, but we have other mechanisms. And certainly, in these patients, in our patients, some of these mechanisms can be present at the same time. So the diagnostic is not always easy, and also the treatment, the management with the treatment cannot be unique. What about the prevalence? If you can read all these papers, all these review articles, the only paper, evaluating in a prospective way a specific cohort is pretty old. It's 1998. This is from our colleague from Japan. Because there is no large prospective study available, only one single institution study, what did they do? They found in their population 260 patients with hematologic disorder, and 10% of these patients show a form of acquired von Willebrand, considering a defective circulating von Willebrand factor activity. And this is a very long slide, so it can be published, so I don't want to go into details. But one of the major problems you should face in these patients, since some of the inherited von Willebrand disease patients can be underdiagnosed, especially in Taiwan, is to distinguish a form of acquired von Willebrand versus inherited von Willebrand disease. And in our experience, we found both things, patients with mild forms of Taiwan and acquired condition producing acquired von Willebrand syndrome. So it's not impossible to have the two things, but certainly what is really important, and it was pointed out in the first presentation, if you can just ask them immediately whether or not in the past, as these patients are usually adult, whether or not they had experienced other bleeding episodes after trigger situation like surgery, you certainly, and you ask history on the family, you certainly are in a very good position to exclude any forms of inherited and favor the diagnosis of acquired von Willebrand syndrome. Why autoantibodies against von Willebrand factor can be important to evaluate? And this these assays are always very picky and very difficult to be performed because of interference of the assay, and we have to approach this in a very good way. But certainly this original paper by Mori showed that if you have high level of autoantibodies, you have high frequency of bleeding episodes. So finding autoantibodies in these patients is really important because the severity of the disorder, of the bleeding disorders, is pretty high. Now we move to the condition associated with acquired von Willebrand syndrome, and I would like to start with the cardiovascular disorder because, as you can see, we have this paper, 1988, that was showing that in aortic stenosis, you see very well, there was in this patient there was a lack of high molecular weight multimers, and only when this is a control of normal patients, and only when you had the surgery, you end up with a normalized value of large molecular weight multimers. And of course, if you have the possibility to treat by surgery these kind of patients, you have certainly a complete remission acquired. And if you check in these patients, as is pointed out, because von Willebrand factor is involved in high shear stress platelet-platelet interaction, we have also found, several authors has found increased proteolysis of von Willebrand factor in patients with aortic valve stenosis. And a sort of type 2A-like acquired von Willebrand syndrome, 77% to 92% of patients with aortic stenosis. And this was published in 2003. So this is the original paper. You see very well that if you check the multimer, you have a lack of multimers, and when you treat by surgery, you recover this kind of patient. Back to the question, is it real a bleeding disorder or just a lab abnormality? This is a case discussed by Warkentin in the Transfusion Medical Review, and it shows that in this kind of patient there is serious bleeding because you can test that there is anemia, and of course you need major transfusion with red blood concentrate, and only when you solve the problem of the valves and you have there is normal hemoglobin in those kind of patients. So you have to give blood transfusion to this kind of patients. So the bleeding is really present. More recently, the mechanical circulatory support was found to be another important conditions associated with acquired von Willebrand syndrome. As you can see, this is a recent paper, state-of-the-art paper published in hematology in the last ASH meeting here in Orlando, by the way. And you can see that there are several pumps, and all these pumps are very important for individuals because they can make patients with heart problem, very serious heart insufficiency, surviving. So these devices are really needed. And I don't want you to read all this kind of condition, but there are classification. This is by a review article published in Journal of Thrombosis Hemostasis by Susan, our French colleague. But what is really important for you is that all these apparatus are associated with von Willebrand factor degradation. And some of them, some others not. But so we know very well that this is very important. And so this is a new condition that we should explore, considering how many old patients, or relatively old patients, are using this kind of devices. Sorry about that. Let's go to the second part of my presentation before discussing the management, and these are hematologic disorders. So one of the conditions that I don't have to discuss other conditions like immunologic disorder, but certainly the two most frequent conditions associated with acquired von Willebrand syndrome are certainly, I'm sorry, can I go to back? Okay, this one. The two conditions are certainly monoclonal gammopathy of uncertain significance. And this is our paper of 1998, where we could follow in a prospective way patients with IgG and IgM gas. And I want to draw your attention on the acquired bleeding symptoms. So these kind of patients had bleeding like menorrhagia, but some of them had also spontaneous post-traumatic bleeding, epistaxis, and also gastrointestinal bleeding. And you see that all the parameters were just consistent with the diagnosis of von Willebrand disease. You see the activity was pretty low in both conditions. And we had the propeptide, as was pointed out before, is pretty normal. Some of them have showed relative loss of large molecular weight multimers. The other condition that is associated with acquired von Willebrand syndrome can be the myeloproliferative syndrome, especially thrombocythemia. It's a sort of paradox. When you have a large platelet count, the larger is the number, the higher is the probability to have defects on acquired of large multimers of von Willebrand factor. This is the first report by Dr. Budde, who just show the number of platelets in this cohort of patients with essential thrombocythemia, and he found that there is discrepancy between von Willebrand factor level as antigen versus its activity. In other words, I hope that I can see the slides. I don't know what's going on. It goes, okay. The slides, you can tell very well that these patients show platelets von Willebrand factor almost normal, but there was a specific loss of large molecular weight multimers. And these patients, despite the fact that they have large platelet, they can bleed. Some of the women can come with heavy menstrual bleeding. Some of them, they have epistaxis. Some of them, they can have also GI bleeding, especially for those patients who are taking aspirin to prevent a thrombotic event in essential thrombocythemia. So this is another conditions. Of course, I can spend more time. I can talk about myeloma. I can talk about chronic lymphocytic leukemia. I can talk about cases about chronic myelogenous leukemia. So following the experience of our Japanese colleague, think about when you have a specific bleeding not associated with low platelet count, think about of acquired von Willebrand syndrome. So let's go to the management. I don't know why it's going. Okay, so the acquired von Willebrand syndrome aims treatment. Of course, we have two possibilities. If we can just try to remove the cause, as we show for the patients with cardiovascular disorder, if you remove the cause of acquired von Willebrand syndrome, like in cardiovascular disorder, you solve the problem. But certainly, we have also to deal with the bleeding episodes every time the patient comes to you with bleeding problems. So we have to have two options: treat the underlying disorder when it's possible by chemotherapy, radiotherapy, or surgery, and we found that surgery was very successful in aortic stenosis, for instance, or to manage acute bleeding. This is a very old slide that it's published in 1985, but gives you the information of a case where we found acquired von Willebrand syndrome associated with non-Hodgkin lymphoma. You can read the protocol of chemotherapy with all these chemotherapeutic agents. And this was reported very easily with a non-Hodgkin lymphoma. You see that the patient had a prolonged bleeding time, very low level of von Willebrand factor activity, because there was a clone of, abnormal, cancer cell in this lymphoma that was mimicking some abnormal interaction like GP1B-like receptor in this kind of cells, cancer cell. So what there was this chemotherapy was pretty good, pretty useful to treat and to put in a partial remission the patient. So when this patient was successfully treated with the chemotherapy, you see that the patient recovered normal level of von Willebrand factor and factor VIII activity. But when the patient had a relapse, again the clones was out, and the acquired von Willebrand syndrome appeared again. So, and the bleeding was appearing again. So this is an example that also in hematological condition like lymphoma, you can deal with the abnormal, von Willebrand factor activity. The second part and the last part of my talk is how we manage the bleeding tendency of these patients since we don't have a single mechanism responsible, we are dealing with several therapeutic approaches. We have DDAVP, we have a von Willebrand factor concentrate with or without factor VIII, high doses immunoglobulin, plasmapheresis, immunosuppressive drugs, recombinant 7A, and there are reports of rituximab in order to block the possibility to produce a specific autoantibody that can interfere with the von Willebrand factor activity. And this is another very big table, so I think it gives you the possibility that one of the most interesting idea is just to try to find the appropriate therapeutic agent according to the mechanism, but is not always successful. Of course, we have patients with underlying disorder, as we said, problem with the hematological disorder, so we have to deal with the specific probably steroid or other chemotherapy can be successful to block the acquired von Willebrand syndrome. In the cardiovascular disorder, as we said, since there is a specific loss of large molecular weight multimers, we should compensate this abnormality by giving concentrates where we have the possibility to reproduce the physiological high molecular weight multimers as we can have in our concentrate. And of course, in other myeloproliferative disorder, we have other condition other approaches to manage the condition that is responsible for the acquired von Willebrand syndrome. But certainly, we should always work case by case. So most of the cases is personalized treatment of our patients. So this is one of the conditions where the hematologists should make their own experience together with the specialist, usually who propose or discuss the case with the hematologist or consultant hematologist. One important aspect we would like to discuss is that, of course, the DDAVP is very useful in inherited von Willebrand patients. As you can see, in Taiwan, for instance, you have a very good recovery. But if you compare Taiwan patients with acquired von Willebrand syndrome, you see that because of the very short half-life of endogenous factor, von Willebrand factor and factor VIII, you don't succeed to have a very good response. So DDAVP can be useful and can be given, but certainly it cannot treat major bleeding. What about the immunoglobulin? This is a case of GUS, IgGM GUS. As you can see, the immunoglobulin can work very nicely. This is the case of von Willebrand factor concentrate in IgGM GUS. The reason why I put IgM GUS is because you can use immunoglobulin in this case because the product containing immunoglobulin do not have IgM. So the only way to give treatment to these patients is to provide enough of von Willebrand factor VIII concentrate. As you can see, there is some correction, but the half-life of the exogenous von Willebrand factor is not quite good if you compare with the inherited type 3. You see there is a loss of multimers, you can correct for a couple of hours, but then you don't have enough salt. So we have to give probably larger doses or continuous infusion. In other words, on the other hand, IgG gas can be treated with large, high doses of immunoglobulin. As you can see, there is a delay. It takes a couple of days to have a sort of improvement, but certainly this can just be a very good approach in this kind of patients. I don't know. Okay, so what you see, as I said, in IgM gas, it doesn't work, and you can give repeated injection in order to make a sort of remission of these patients. We were very successful to manage GI bleeding in IgG gas by giving every 20 days repeated amount of high doses immunoglobulin. This is one of the last reports about high and repeated dose of available factor concentrate in patients with cardiovascular disorder with the left ventricular assisted device. You see that these are the number of blood transfusion. When these colleagues treated a patient with the left assisted ventricular devices, you see that the patients recover very well. So this is a positive example that by using appropriate amount of available factor concentrate, you can correct the loss of large molecular weight multiple cardiovascular disorders. I'm sorry. So, and of course, we have recombinant activated factor VIII in acquired von Willebrand syndrome. This is only one single report, but if you are desperate, if you don't know anything about, and all the other therapeutic approaches are not very good, you can just treat your patients with the same protocol used for acquired hemophilia. 90 milligram per kilo bolus plus 17.5 microgram per kilo hour for 6 days of recombinant 7A in a very desperate situation. So this is my last slide. I want to give you a sort of summary, and certainly I would like you to take home this message, that is a condition that is very difficult to be diagnosed, but we don't have to forget that there is a possibility of these patients. And we have to increase the awareness on acquired von Willebrand syndrome. And for doing this, this is my last presentation. What we are doing on the subcommittee of von Willebrand factor of the International Society of Thrombosis and Hemostasis is to start just to increase the awareness, to have a sort of interactive registry online that is called Intra-Will Maps, meaning interactive registry on acquired von Willebrand syndrome management prospective study, to make sure that all the information will come out and will be available for most of our colleagues hematologists working all over the world. And I thank you for your attention.